Today I'm going to share some reflections about having worked as a behavioural scientist over this last 15 months on COVID-19 in the UK. I'm Susan Michie, I'm Director of UCL's Centre for Behaviour Change, and here there's something about the several things we do. It's cross-disciplinary, translational, and a variety of different activities if you're interested in looking at that. My role as a COVID-19 scientific advisor has been to the UK government via the Behavioural Science Advisory Group in SAGE. Also, I'm a member of Independent SAGE, and I've served as a COVID-19 consultant to WHO's Behavioural Insights team. So, human behaviour is at the heart of causing and transmitting pandemic infections and at the heart of preventing and getting out of them. And we're talking about many different people's behaviours: citizens, health professionals, employers, service and environmental planners, policymakers at national and local level, politicians, the list could go on. But citizens' behaviour, particularly, there are several groups. There are the personal protective behaviours that we're all very familiar with. There are also adherence to public health measures, for example, the test, trace and isolate system, and to restrictions like border controls or staying at home. And finally, vaccination uptake is itself a behaviour. And there's a science of behaviour, hence the SAGE Behavioural Science Group. And this is multidisciplinary. We have people from psychology, sociology, anthropology, with expertise in communications, inequalities, implementation, and across many specific domains. And we publish a huge number of reports which are available on the government website. SAGE is a very large and complex organisation with many groups and people feeding into it. It incorporates this huge scientific talent that's worked incredibly hard since February of last year. It works in responsive mode, so works to commissions from the government. And there are often delays between the reports being agreed and them being signed off for publication. Another issue I draw attention to is that the translational pathway between the advice given and what happens to the advice is not transparent. Following the science, I think we've all heard this phrase many, many times. And I want to address here, did this happen? Should this have happened? And what should be the nature of the science policy relationship? So the answer is it happens sometimes. And I'm going to give 3 examples of ways in which science wasn't followed. Firstly, test, trace and isolate. Advice is still not implemented. Moving from 2 meters social distancing, advice was circumvented, and delaying lockdown and using a term behavioural fatigue was an instance of scientists being blamed. So, first of all, test, trace and isolate. WHO, right from the beginning, really stressed the importance of this as a cornerstone of the pandemic response. In red below here, we have WHO officials stress the importance for countries to test, isolate and trace new cases to suppress the spread of the virus. And you probably remember saying test, test, test. So UK government chose a national commercial contract at an eye-watering £37 billion so far, rather than delivering it in local public health, as has been effective in many, many countries across the world. And unfortunately, this has been not successful. Even now, testing's very slow turnaround compared to other countries. Tracing, only a proportion of contacts are given by people, and only 80% are followed up. And self-isolation, only 50% self-isolate even when people are symptomatic. Now, these figures are far below what is needed for an effective test, trace and isolate system, which is our only way of dealing with outbreaks as they happen, which they inevitably are and inevitably will. So problems: getting tested, giving contact, self-isolating. The UK estimate of the percentage of symptomatic people required to isolate to effectively reduce transmission is 80%. But our weekly survey that we started at the beginning of the pandemic of around 2,000 people nationally every week has found that only about 50% of people self-isolate. This is far below what is required. People are interested, it's written up in the BMJ paper. So why is this? Often the assumption is that the problem is one of motivation. But is this the case? In order to think about this, we need a way of thinking about behaviour. And I'm going to present the simplest yet comprehensive model of behaviour that myself and my colleague Robert West developed. It's called the combi model. So behaviour occurs as an interaction between three necessary conditions. You could just try a thought experiment. C, O and M are the first letters of the three things that need to be in place for any behaviour to occur. So first of all, a behaviour won't occur unless there's the capability. But in addition, it's absolutely essential to have the opportunity. But one can have the capability and opportunity, it still doesn't happen unless there's the motivation. And as you can see, these form a system. So changing one of these entities has a knock-on effect on the other. And these can be further broken down, capability into psychological, like knowledge and skills, and physical, motivation, the reflective, the top-down, conscious decision-making and choice, but also the important automatic mechanisms of emotion, habit, drive, impulse, etc. And their opportunity is the physical environment, but are incredibly important social environment. Now, all of these can be disaggregated into many theories, but this is a top level model. So, is the problem of self-isolating to do with motivation or opportunity? Well, let's look at some socioeconomic differences. This study was done by Helen Ward and colleagues at Imperial. They found that 87% were willing to self-isolate across all income levels, but those of the lowest household income were 3 times less likely to be able to self-isolate and 6 times less likely to be able to work from home. The problem is mainly lack of opportunity. And in our study, we found predictors of low income and jobs with low income and financial hardship. And the reasons we found were caring responsibilities outside of the home, needing provisions, and problems in terms of work, income, and employment. SAGE's advice, and that from SPI-B to it, has been clear throughout. What's needed is more practical and financial support. Here are minutes from September 2020. So really stressing that if we're going to get the numbers up, people mustn't experience financial hardship. Just to remind you, statutory sick pay in the UK is only £96, which is 16% of the average pay. If you look at OECD countries, the average is 70%, and many in North and Central Europe are paying 100%. So in these circumstances, the government offered those on low income £500 over 14 days, or it's now 10 days. But this is less than the minimum wage. And only 1 in 8 people are eligible to apply. And of those who apply, only 30% receive it. And in addition, a fine of up to £10,000 has been imposed. Now, the behavioural scientist group in SAGE have consistently said the strategy that should be used to support behaviour is to enable, to support people to do the right thing, because most people want to, not to punish or blame. And, obviously, we would predict negative consequences of putting up such a fine as this. And there's a concern that fewer people will get tested or give contacts or download an app. Because why would you get tested if you can't afford to self-isolate? Why would you give contacts if you don't want to put your friends and family in a similar situation of risking a £10,000 fine? Interestingly, the mass testing that was evaluated in Liverpool found that only 8% in disadvantaged communities got testing. And our study, the weekly Corsair study, showed that only 20% of those with symptoms say they got tested. So we've got big problems here. Another big issue is that other countries, even poor countries like Vietnam or Uruguay or Kerala in India, they offer alternative accommodation if you can't isolate at home. New York City offers free accommodation in local hotels, free transport there and back, free Wi-Fi, free food, even childcare and pet care where it's needed. We're offering nothing. There's something being piloted now, but that's it. A couple of local authorities are trying to do it on their own. They don't have the budget. Obviously, how many people can properly isolate at home, which is why there's been so much transmission within households. So here are a few headlines. People who just can't afford to self-isolate, workers with COVID too scared to get tested in fear of losing wages, Liverpool mass testing not reaching city's poorest people. So moving on to a second example, moving from the 2-metre social distancing. Here, back in June 2020, SAGE continues to advise at least 2-metre separation where possible. However, what did the government do? They set up what they said was a Downing Street review of, quote, scientists and economists, but we never heard who the members were, what evidence was reviewed, and never saw a report. Yet, the chief medical officers of the 4 nations agreed to move from 2 metres to 1+ metre. In effect, this just ends social distancing as a policy because unless you're intimate with somebody, actually a metre is about how far you stand from somebody. So this was an example of SAGE being bypassed when the science wasn't convenient because they wouldn't change their scientific advice. So it's an example of kind of pick and mix. And I should say that following the science was a phrase that never rang true to me or other people who've been used to working with policymakers. I've been working with government policymakers for decades now, and I'd never expect the government to follow the science. I would hope they'd be informed and consider deeply the science. So the next example is actually where scientists were blamed. Most recently, we heard Dominic Cummings attack behavioural scientists and attributing lockdown delay to us saying the British public will not accept a lockdown or what was thought of as an East Asian style track and trace type system. However, if you look at the minutes from 12th of March of last year, we stressed that if the public are concerned that interventions are perceived to be effective and not applied, that would be a problem. And the next day, the behavioural considerations at SAGE, where we have up to 3 behavioural scientists at the SAGE meeting, talked about any difficulty in maintaining behaviour should not be treated as a reason for not communicating with the public about the efficacy of the behaviours and should not be taken as a reason to delay implementation where that is indicated epidemiologically. So very clear that this didn't come from us. Behavioural fatigue, I don't know if you remember this being bandied around last spring. This is not a behavioural science term. There's no measure of it. It's not included in any theories. There's no evidence base about it. And it was never mentioned by our committee, either in any discussions or in reports. And there was an open letter signed by about 600 behavioural scientists in March 2020 saying, urge the government to share an adequate evidence base if there is such a one. But if one is lacking, urge the government to reconsider their decisions in relation to behavioural fatigue. And myself and colleagues Robert West and Nigel Harvey wrote an article in the BMJ really looking at what is meant by the concept of fatigue and really pulling to bits this idea of behavioural fatigue. And it was actually chosen, the editor's choice, for an editorial that week, saying a flawed idea central to a flawed pandemic response. So moving on to thinking about what's the responsibility of social and behavioural scientists in this situation. An interesting Guardian commentary kind of challenged us, saying if the science was not followed, scientists have a right and an obligation to ask why not. They should not passively resign themselves to the on-tap status assigned to them by Winston Churchill. So an interesting challenge that I want to look at a bit more here. What should the science-policy relationship be? On the one hand, we're not elected officials and we're often unfamiliar with the policy context. On the other hand, evidence does not implement itself, and policymakers often don't understand the scientific advice nor how best to translate it. And translation and implementation are themselves the subject of scientific inquiry. And I think this is something that is really not understood by many of our medical colleagues who are involved with COVID-19. So, a couple of questions. Shouldn't social scientists be asked to advise on the translation process itself? Because obviously it's not just giving advice that is important, it's what happens to that advice. And secondly, shouldn't scientists work in partnership with policymakers at every step along the translational pathway? Here we have two views, both from ex-government chief scientific advisors. We have Sir David King, who wants being very open and transparent about science and talks about government scientific advisors as bridges between current science and the political system. And at the top there, I've got a picture of a bridge with a hand holding the bridge up. And also saying that the advisor's role should also not just advise government, but inform the public. On the other hand, we have Sir Mark Walpott, who is very clear that there's a difference in terms of scientists advise, but politicians decide. That is fundamental. Now, obviously those things are true, but the emphasis there is that and I put a picture of a wall up there, that you have advice on the one hand and decisions on the other. And these two things are separate worlds and shouldn't get entangled. And I have to say, I've seen that point of view expressed many times by various people connected with SAGE. What lens should scientists use? Again, Mark Walpott, in the same interesting series of articles, said that the policymakers looks through three lenses. What is known about this issue? Is this policy deliverable and what might be the consequences? And thirdly, how does this policy fit with my own personal and political values? And attributes the first one to being the scientist's role. So scientists just have that one role, but policymakers have all three roles. Now, I would raise the question, shouldn't social, behavioural and indeed all sciences look through all three lenses? And in my question is actually my view too. So the mantra, another mantra that we've heard among some of the scientific community, scientists advise, politicians decide. And I know this is done in good faith because it helps to protect scientists. And I can see the point of that. We do not want to be blamed for policy decisions. But the problem is, I think that's an artificial divide. And I think whilst I understand the motivation for it, I think it is at the detriment of effective translation and implementation of the advice. So there's a very complex translational pathway from scientific advice to policy and practice. And there is a huge, interesting science of implementation. I was one of the founder editors of a journal called Implementation Science. And here is a commentary written called Implementation Science in the Times of COVID. But there's nobody on SAGE that's tasked with this looking at the science of implementation. As I said, it's SAGE on the one hand, policymakers and politicians on the other hand, and we're asked to write reports in accessible ways, but not even to give policy examples because that's too light policy, even though those of us who have done a lot of work with policymakers know that actually concrete examples is what brings the more abstract scientific advice to life. They're hooks that they can really attach to in terms of understanding what's being said. So I think this is a really important discussion that needs to continue in the future. And just to illustrate here, this was one of the papers I led on for SAGE, which was looking at the possible impact of the COVID-19 programme on adherence to rules and guidance about personal protective behaviours, because we knew there was evidence and current surveys suggesting that people would relax their behaviours and that this maybe undermine the suppressing the transmission. So I, having led this, I did a teach-in for Cabinet Office and many others in government, but I was getting very alarmed about all the reports that were coming back where people had been vaccinated with no leaflets or with very dry, long leaflets and no messages from the person vaccinating them to remind them or give them new information that the immunity wouldn't be instant. It would take 2 or 3 weeks to build up, that we didn't know how long immunity would last for, and we didn't know how much their infectiousness would be reduced. In view of that, I managed to get introduced to somebody from NHS England and worked with her to take the essence of this report and produce in 16 different languages a downloadable animation that people could have on their phone, giving these main messages, poster and leaflets for the vaccination centres with a QR code, and guidance, very simple guidance, 3 main things for those giving the vaccination to say. And this is what they looked like. The leaflet, the poster and the guidance. Now, I can't ask you to put up your hands, but I have yet to come across anybody, and I've been asking many people, who got this leaflet, saw this poster, got this animation. So why not? There was no implementation plan as far as I know. There was no monitoring of the uptake or the evaluation. So this is as far as I've ever seen anything implemented. And what a shame. A lot of really good work and resources went into this. And because people aren't drawing on the science of implementation, because scientists aren't working with those along the translational pathway, there's this sort of problem. I don't know if how many of you are familiar with MRC's framework for complex interventions right back in 2009. And this is in a circle. And the point is that one of the main points they wanted to get across was think about implementation right at the beginning, before you develop any studies, before you do the feasibility and piloting, before you do the evaluation, so that the understanding of the complex ideas about how it would be disseminated, how it would be implemented, were built in right from the beginning. And, where are we? Almost 20 years later, and not quite 20 years later, 13 years later. And this isn't at the heart of the scientific advisory process. And one of the main points I want to make in this talk is I absolutely think it should be. Implementation scientists should be involved and should be working with a whole range of scientists and their advice, and a whole range of policymakers and practitioners. And just to mention, SAGE is the main group giving scientific advice. There are also scientific advisors in Public Health England, in government departments, in the Cabinet Office itself. And a very interesting independent SAGE that was set up, and I'm a member of, by Sir David King, a former Chief Scientific Advisor, at the point when he was very disturbed by the fact that the SAGE membership was secret, the minutes and reports were secret. And the plan had been for a single meeting and a call to action. But the need for it became very clear, especially when the Prime Minister ceased the regular public and press briefings. So we have carried on every week since last spring, which is a huge amount of additional work, but very satisfying. And although I don't think we have an influence on government, we have many members of Parliament coming and asking questions. I know from the nation governments, we've had very good feedback, and from local authorities. So there are different routes in to getting scientific advice across. So it has a website. We have almost 1,000 followers on Twitter, and we do weekly press and public briefings where we update on the data, and very open, getting people's questions and answering them. So we have up to 20,000 at a time and 17,000 subscribers to the channel. And the aim is to put scientific evidence and debate into the public domain on the basis that openness and transparency leads to better understanding and better decision making, and on the basis that there's a responsibility of scientists and those with specialist knowledge to engage with the public and policymakers in order to ensure that science benefits all of society. So this is very much about policy-orientated scientific advice. Again, a different emphasis. And I do think this whole area that I've just really begun to think about over this last year is one that requires much more analysis and discussion, and indeed academic thinking and research. It's very agile, very proactive. We don't wait for questions to come to us. We think about what's a need at the moment. We've produced more than 80 reports that are all on the website. And we also have invited guests on different issues. It might be to do with the new variant, it might be to do with mental health, it might be to do with inequalities, whole different range, and very stimulating. I want to finish with really looking at inequalities, which I think we're all painfully aware of, have really increased over this last 16, 17 months. We were already a very unequal society, and we've become much more unequal. Partly because of the virus itself. We know that it transmits more in overcrowded, multi-generational households and public-facing unsafe jobs. And we know that there's increased harm for those who are susceptible because of a history of disadvantage and other health conditions. Then we had the whole problem about the UK's lack of preparedness, underinvestment in public health, which was so painful to see the results of that, underinvestment in the NHS and in social care. The poverty, the inequality, the structural discrimination that we're seeing playing out, and I've already mentioned about testing, but vaccine uptake too. Insecurity and living and working lives got a whole lot more critical. And then the UK strategy itself, which was a containing rather than suppressing. And I would commend this recent Lancet commentary that looked at OECD countries and found or showed that the elimination, trying to get rid of it, so it's very, very low level that could easily be contained by a good test, trace and isolate system, rather than just mitigation, creates the best outcome, not only for the health, but also for the economy and civil liberties. So the narratives that have pitted these things against each other are just not borne out by the data. And then fourthly, we have a whole tranche of government policies that instead of making things more equal, has done the opposite. So I've mentioned about the lack of financial and practical support for people, the differential protection with those most disadvantaged getting least, the lack of PPE, again, hitting those who are on the front line, lack of safety measures in schools and other buildings, big educational divide, which was been so tragic to see, not giving school students the laptops, the connectivity, the places to study that was needed to stop this happening. Issues about lack of furloughing for women, and so many ways in which Black and ethnic minoritized groups have suffered disproportionately across the board. And we are really looking now at COVID becoming a disease of poverty. This is something that is not necessary, and I desperately hope that we may get changes of policy. But unless things are very different than they are now, this is going to be the consequence. Here we have average case rates on the left, and you can see the green is least deprived, red is most deprived. On the right, ICU admissions. Pretty well, whatever you look at, whether it's testing, whether it's vaccine uptake, whether it's long COVID, whatever it is, this is the sort of pattern you see. It's very, very stark. And many reports are emphasising the problem. Here we've got the National Audit Office not so long ago saying that, talking about the risk of widening inequalities. We had the House of Commons Science and Technology Committee making the point that those people who were looking at people's livelihoods, educational progress, mental and emotional well-being, much less transparent, and those giving advice and their role much more obscure in decision making. So this is a big problem. Right, and I'm going to finish on the future and building back better. There's a lot to think about, I think, in terms of what I've said. There's a lot of things that have gone badly wrong, and I've just scratched at the surface of some of it. But we do have a chance to think about resetting society. We don't have to go back to how things were before. We don't have to accept that things are going to be worse than they were before. So I just want to touch on some areas to end. First of all, infrastructure changes. Our school classrooms are about the most crowded in Europe. We could get better distancing. We could get ventilation in all those public buildings that are shared. We could do what public health experts have advocated from the beginning and what countries all around the world are doing, which is to locate, test, trace and isolate in local communities where the experts know the communities, where the communities trust the experts. Decreasing inequalities. So many different ways in which changes in government policy could really help. This is a political choice. Thirdly, we could retain the improvements that there have been. So more active transport, working from home where possible, infection control behaviours being part of the culture. You know, we know that in many other countries, there's much better routine hand hygiene. There's routine use of masks in indoor enclosed spaces. And I think we should think big. Think about very different ways we could be doing things. So part of working at home, I mean, some people don't have homes where it's easy to work. In fact, many people, maybe most people don't. And we are social beings. We want to have interaction, stimulation with other people, but rather asking people to travel hours again every day in and out of work at the cost of their physical and mental health, at the cost of the quality of their home life and recreational life, and at the cost of the climate and the future of the planet. We could begin to think about new working hubs in local communities, where people could, or employers could, rent desk space for however many days a week people wanted to work. It could be themed according to different types of work. People would get to know people in their communities, and this could mean then much more investment in local communities. There's been a real issue about left behind communities, under-resourced, underserved communities. This could be turned around and make communities thriving again. And thinking about the employment, think about how much of our employment was in the financial and service sector. What about thinking about what we didn't have, what became painfully aware that our manufacturing industry isn't fit for purpose? We weren't able to make PPE and all the other things we needed, the protective equipment. We had to import them, scrabbling around at the last minute, often buying things that weren't fit for purpose. Let's get our manufacturing industry going again, and let's do it with a green agenda. There's so much work that needs being done to deal with what is the bigger existential crisis, which is the climate emergency. What would be great is if the government and the population could really think about how to change society so that not only are we more resilient to the next pandemic, because they will be coming on probably at a faster rate than they have previously given the environmental degradation, but also make this planet more resilient to the climate emergency. And I want to finish on a final note that no one is safe until we are all safe. In this talk, I have been talking about the UK, which is what I know best. But nobody will be safe until we get the whole world safe in terms of COVID. And that means rethinking our vaccination programme very rapidly, I would suggest an urgent summit. Obviously, the patents on vaccines should be waived, as they were for HIV medicines, and also the whole production of vaccines in other countries should be supported and developed. So I want to end on a note that a better world is possible, but also end on that note that we are part of a global community and we have a responsibility there as well as in the UK. Thank you.